Autosomal dominant polycystic kidney disease, ADPKD, profoundly affects renal architecture, leading to drastic ultrasound findings. The kidneys become grossly enlarged, often bilaterally, presenting a distorted shape that captures the eye. As cysts proliferate throughout the renal parenchyma, their varied sizes replace much of the normal tissue, contributing to a striking visual of numerous anechoic cysts. With well-defined walls, these cysts typically enhance posterior acoustic signals, though some may present internal echoes if complications arise from hemorrhage or infection. A notable feature of ADPKD is the loss of cortico-medullary differentiation, where the normal distinction often vanishes amidst the chaotic arrangement of cysts. As their numbers swell, only a compressed and echogenic residual parenchyma might remain visible, hinting at the functionality still left within the affected kidneys. Color Doppler imaging adds a layer of depth to the diagnostic picture of ADPKD, revealing a strikingly reduced vascularity. This diminished blood flow arises from the disease's relentless replacement of functional renal tissue by cystic formations. Though flow patterns in the residual parenchyma may retain some semblance of preservation, they generally diminish alongside disease progression. Another telltale sign observed in patients with nephrolithiasis, a common complication of ADPKD, is the twinkle artifact on Doppler imaging. This phenomenon hints at the underlying structural changes within the kidneys, marking an area of potential concern. Differential diagnoses for ultrasound and Doppler findings are critical in distinguishing ADPKD from other renal conditions. Acquired cystic kidney disease, ACKD, features non-enlarged kidneys with uniform cyst sizes, while multicystic dysplastic kidney, MCDK, typically appears as a non-functional unilateral mass. In contrast, simple renal cysts present as solitary entities, and medullary sponge kidney displays small cysts without gross enlargement. As ADPKD progresses, it inevitably leads to a gradual decline in renal function, often culminating in end-stage renal disease ESRD by the 5th or 6th decade of life. This trajectory may be punctuated by complications, including hypertension stemming from renal ischemia, while renal cyst infection, hemorrhage, and an escalated risk of nephrolithiasis provide further challenges. Beyond the kidneys, extra-renal manifestations like liver cysts and aneurysms exacerbate the clinical picture. Management strategies focus on routine monitoring through imaging and renal function tests, alongside addressing hypertension with ACE inhibitors or ARBs. Lifestyle adjustments, such as ensuring adequate hydration and avoiding nephrotoxic medications, play crucial preventive roles in managing ADPKD. While advanced therapies like Tolvaptan offer hope of slowing both kidney enlargement and functional decline, the integration of these modalities can significantly impact patient outcomes and the quality of life for those living with ADPKD.